Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I am your host, Dr. John Hausman. Show notes for this episode can be found at acronair.org. You can also find our previous episodes on Apple Podcast, Spotify, and on your favorite podcast app. Osteoporosis affects 200 million people worldwide and is particularly common in those with rheumatic disease. But what should be the role of the rheumatologist in helping to prevent or treat osteoporosis? Our guest today is a rheumatologist who has created innovations in the field of osteoporosis. She strongly believes that in order to take care of the whole patient, rheumatologists should be involved in managing their bone health to help prevent disability. Dr. Marcy Bolster is professor of medicine at Harvard Medical School. She's the director of the Rheumatology Fellowship Training Program at the Massachusetts General Hospital. She sees patients in the Rheumatology and Endocrine Associates Outpatients Clinic. She led the efforts to create a fracture liaison service at MGH and served as its medical lead. In today's episode, we'll discuss the silent epidemic of osteoporosis and how often it's under-recognized, even after patients have experienced fragility fractures. She will discuss the program that she created, the Fracture Liaison Service, to help diagnose and treat patients with osteoporosis as soon as a fracture is identified. We'll also discuss how she screens for patients with osteoporosis and rheumatic disease, and how she evaluates the various treatment options available, and how she discusses them with her patients. Enjoy. Marcy, welcome to the show.
Hi, John. Good morning. It's nice to be here.
So, why should rheumatologists care about osteoporosis?
That's a great way to start. I think rheumatologists should care about osteoporosis because it's part of taking care of our patients as a whole. Looking at a patient's bone health is just part of taking care of the patient. We certainly give medicines that can contribute to bone loss. And so particularly in patients who are on glucocorticoids, we should address their bone health. But I think of that as just a reminder that we are capable, we're skilled, and we can help look at our patients in their entirety.
Yeah. And, you've had a interest in osteoporosis for a while now. Can you tell me a little bit about how you became interested in that field? Because it's certainly not something that I learned much about in my fellowship, and many rheumatologists don't have much experience with osteoporosis or its management.
I think I became interested in osteoporosis when I realized that it was something that was honestly pretty easy to take care of for our patients. It wasn't so complicated when I started delving into it.
Fewer options, I take it.
There were fewer options. And we also used those options for a long time. We weren't addressing drug holidays. And so I think that my interest started in osteoporosis because it really was something I could identify, I could address, I could discuss with patients, I could educate patients, and I could do a good job at it. And I think somewhere probably in the back of my mind, I also knew that my grandmother suffered from osteoporosis and increasing debilitation from it and ultimately died of osteoporosis.
Oh,
and
my goodness.
I don't think it was actually, okay, my grandmother has osteoporosis. I'm going to learn about it and I'm going to embrace this challenge and, I'm going to provide victory in this disease. But I think it just, we have these little things in our lives that help shape the way we practice. And so that probably had something to do with it at some level. But I do think, kind of also addressing your first question in terms of why should we care about osteoporosis, we care about so many things as rheumatologists that contribute to disability for our patients. And osteoporosis is really often silent process and problem. And by knowing that we have the skill set to identify it and manage it for our patients, it just gives us kind of one step up to being able to help our patients in a very comprehensive fashion.
Yeah. And I guess you're right. So initially you mentioned that some of the medications that we use to treat their rheumatic disease may place them at increased risk of developing osteoporosis. But I think the other part is important too, that the patient population that we serve is generally elderly, is often women, and this patient population is at particular increased risk of osteoporosis. So we treat a patient population that's at risk, and I like what you said, Marcy, that we have the skills to be able to intervene and manage. And one of the things that I'm struck by is how infrequently osteoporosis gets recognized. So
Mm.
we've all taken care of patients that have had, you know, vertebral fractures or that have had other fragility fractures, and nobody ever identifies, hey, that's indicative of osteoporosis. Why do you think that is?
I think it is exactly as you said. It's just under identified. I think also the patients that develop osteoporosis often have a lot of other comorbidities. And
Mm,
so their providers are addressing a lot of other things. And osteoporosis is not necessarily symptomatic until there is a fracture. And we'll get back to that vertebral fracture question, actually. I'd like to follow up on that. I also wanted to mention, though, that I've really embraced the challenge of learning about osteoporosis and teaching about osteoporosis. And, for our fellows in my own institution, and then anytime I have the ability or opportunity to interface with other fellows, I love to talk about osteoporosis. And our fellows, for instance, rotate with me in a dedicated osteoporosis clinic, even though I'm not an endocrinologist and don't you dare ask me questions about thyroid. um, I have a clinic in the endocrine clinic, and I see patients a half day a week there, and our fellows rotate there. And I think my goal with that is to weave osteoporosis and bone health management into the care that our fellows are providing every day to their patients with rheumatic disease. And by having these tools in their toolkit, they really just look at it as part of the comprehensive care of the patient. The
mm,
other thing I'll add, actually, John, is that, you mentioned that a lot of our patients are older and they are more susceptible to osteoporosis, but even our younger patients who have inflammatory disorders like inflammatory arthritis or lupus are at increased risk for bone loss, even without looking at the medications that we use, such as glucocorticoids.
great point. So it's not just the medicines that we give them or their age, is also these chronic inflammatory diseases that make them at increased risk.
Exactly.
And, so do you envision rheumatologists taking care of osteoporosis in patients with rheumatic diseases, or rheumatologists taking care of osteoporosis in general?
I think it can be both. I think we absolutely should take care of osteoporosis and our patients with rheumatic diseases. Our patients look to us as providing so much of their care. And some of the bone health can really be addressed by primary care, and it can be a collaborative approach with the primary care provider. But I think that rheumatologists can be equipped to take care of the bone health problems for our patients who we're already seeing for their rheumatic diseases. And then I also think that we get referred patients because somebody wonders if they have a rheumatic disease, and sometimes they don't. But we have that opportunity, we have that moment where we can also address the bone health. And even if that's as simple as ordering the DEXA scan and then collaborating with the primary care doctor to ensure that the patient gets good care for their bone health, that's certainly a possibility.
Fantastic. So tell me about your approach of evaluating patients for osteoporosis in your rheumatology practice. In whom do you think about ordering that DEXA scan, and how do you think about managing the results?
I think it's hard to say this 100% for sure because we're never 100%. But I like to think of as I'm kind of going through the algorithm in my mind as to taking care of my patient and what problems I need to approach with the patient, I include their bone health. And so every patient, so this is where I can't say it's 100%, but I hope it's pretty close. Let's just say, for every patient, I consider whether or not their bone health has been addressed. And I check to see if they've had a DEXA scan within the past couple of years. And if anybody's addressed it, I'll ask the patient if they know about having had a DEXA scan or know about having osteopenia or osteoporosis. And then I take a moment and ask them if they've had a fall as an adult, ask them if they're taking calcium and vitamin D, and ask if I can go ahead and order the bone density test or address their bone health with them if they've already had a bone density test, a DEXA scan. And the other thing that I love about precepting the fellows is that they know they're not going to end their visit without addressing the bone health and of the patient with me. Because it really becomes, it's just part of their visit with each patient. And I think they do this when they are precepted by other faculty as well, where they're addressing the bone health.
Yeah, absolutely. I can attest to that. And tell me,
Awesome.
so DEXA scans in a 70-year-old that's never had one is easy. How about a 40-year-old with rheumatoid arthritis, or a 50-year-old male with axial spondyloarthritis? In which in these cases, do you always also order a DEXA scan, or are you a little bit more selective about when to order these tests?
Yeah, I think in the premenopausal women, it's a little bit less clear. In general, premenopausal women are less likely to fracture. However, if they have a lot of risk factors, or certainly if they've been on glucocorticoids, then they might be more prone to fractures. And really the goal, I think, the reason we want to detect osteoporosis is because that equates to increased fracture risk. And premenopausal women, they're not on glucocorticoids, but say do have an inflammatory condition like rheumatoid arthritis. If they haven't had a big steroid burden and aren't on glucocorticoids, although they are at increased risk for bone loss, and I think the importance of exercise, calcium, and vitamin D could be discussed, they aren't necessarily at high risk of fracture. So I think it's an individualized decision. And in terms of men over the age of 50, men over 50 are at increased risk. It's really less clear when we would define that men should start getting DEXA scans. The Bone Health and Osteoporosis Foundation, formerly called the National Osteoporosis Foundation, the NOF, has recommended DEXA scans for women, postmenopausal women over the age of 65. And for men, they recommend over the age of 70. But there certainly are men who fracture in their 60s. And so, again, it's kind of an individualized decision.
Got it. So for postmenopausal women less than 65 with rheumatoid arthritis, you would think about screening those people as well.
Yeah, I think that's a great point. Yes, I would.
Okay. Got it. So it's sort of an individualized approach to...
It is. And, our patients with lupus who are on glucocorticoids or who have systemic vasculitis on glucocorticoids and who are premenopausal, I think that it's useful to get a DEXA scan so that we see where they are with their bone health. And it's a complicated question depending on the age of the patient and their wishes to have children in terms of medications that we could recommend. I mean, the new GOP guidelines, without going terribly deep into those, as they are a bit not only comprehensive but tedious, but the PTH analog teriparatide has a really high level recommendation let's not say high level recommendation. It is recommended as a first option for treatment of patients with GOP. And so you could consider that in your premenopausal women. I think it can be hard, from personal experience, it can be hard to get it approved, but maybe now with the GOP guidelines to support it would be easier.
Yeah, for listeners interested in learning more about the GOP guidelines, we did an episode with Dr. Mary Beth Humphrey, who's the, I think the lead author on those guidelines a few months ago. And you're absolutely right, Marcy, that they are complex and comprehensive, I guess, at the same time. So they have a lot of recommendations, and depending on the risk factors of your patients. So looking into those guidelines for advice, I think, can be very helpful. So, all right, you order your
Just to
Dex.
follow up on that,
Yeah.
sorry, John, just to follow up on that one more item is that the teriparatide there doesn't seem to be concern about teriparatide in terms of women in their childbearing years, whereas with bisphosphonates,
Okay.
because they're so avidly bound to bone, there's concern about what effects the bisphosphonates could have on an unborn fetus. And so that's why I bring up that teriparatide would be of consideration in the premenopausal woman.
Love it. Yeah, because we all, in children with rheumatic disease who may be at high risk for developing osteoporosis, or when we're thinking about using bisphosphonates in younger patients, that is one of the concerns. Is
Yeah. Yeah.
it will for future pregnancies. All right, so you order a DEXA scan, and somebody's score is less than -2.5, and you think they have osteoporosis. How do you think about choosing the right treatment for each patient? Do you start with alendronate for everybody, or are there certain cases where you think about anabolic agents?
Yeah, that's such a great topic to think about. First of all, I would say I really like this to be a shared decision with the patient. So I like to lay out all the different options to the patient, kind of like we would do when we see a patient with new rheumatoid arthritis, and talk about the different treatment options. And I think that there are some people that kind of come to the visit with, there's no way I'll take such and such a medicine, or my neighbor's great aunt takes something like this and it's a shot, and can I have that? So people come to the visit with some notions of what they may or may not think is reasonable for them. But I really approach it as, my job isn't to tell you what to take, it's to educate you on what your options are, and let's find the thing that's the best fit. Because we do know that, particularly with the oral agents, at 1 year of prescription, only about 50% of people are actually still taking.
Wow, I didn't know
Yeah,
that.
it's really low. Yeah, it's not necessarily 50% of people tell their doctor that they're still taking it, but 50% of people are still taking it. So the adherence rate is really low with the oral agents, but there's some people who just really prefer oral, and they're dedicated to it, and they're going to do it, and they tolerate it well. So I think I start the conversation with oral bisphosphonates, and alendronate is the most readily available. But I also include IV bisphosphonates, such as zoledronic acid. I will discuss denosumab. A lot of people are familiar with denosumab and are
Yeah.
really in favor of taking it. But I also think there's some downsides with denosumab in terms of, if patients miss a dose, there's the risk of sudden loss of bone density that has been reported to result in to lead to multiple vertebral fractures. So I think there's some downsides to denosumab. You're not able to stop it for a drug holiday without following it with something else. So again, I think it's just a decision that's personalized to the patient. And then there's the question of anabolic therapy, and that would be with the PTH analogs or romosozumab. And keeping in mind, romosozumab is very unique in that it's anabolic and anti-resorptive. So it's the one agent that we have that kind of does everything. And the patients, to kind of follow up on your question, like whom would I consider an anabolic agent? I think a patient who's had multiple fractures, particularly vertebral fractures, should be strongly considered for an anabolic agent. But then patients with severe osteoporosis, defined by T-score less than -3, I would also consider an anabolic agent. And there have been people in the bone world for years who have talked about this kind of anabolic window.
Mm.
And it really is coming to light for a couple of reasons, that it might make sense to build bone before you then give an agent that prevents bone loss. And to add to that, there are data that show that if a patient takes an anti-resorptive agent first, followed by an anabolic agent, that they get a blunted effect. So
Mm.
taking anabolic agent first allows a greater impact on building bone and then maintaining it.
Interesting. And I wonder if things are shifting. I remember learning about how you treat patients with HIV, and for a long time we were waiting for their CD4 counts to drop
Mhm.
before starting antiviral agents because we
Mhm.
thought that, well, if you start too early, they might develop resistance. And I wonder if it's sort of the same with the treatment of osteoporosis, is that rather than waiting until they have all of those vertebral fractures, why don't we help them build bone first and then maintain their bone with a bisphosphonate later, rather than just doing a bisphosphonate. So do you think people are being more aggressive about treating with anabolic agents recently?
I think so. And I think when we have that discussion with patients, that they're really open to it.
Hmm.
Because if you explain that we have the opportunity to build bone and then try to maintain that, there's some patients that are really interested in being proactive about it. And I will also kind of brag about our fellows in that they're really facile with these anabolic agents. And they've started teriparatide or abaloparatide or romosozumab on many patients. In fact, I can remember one clinic, I think we started romosozumab on 3 patients in a
Wow.
fellow's clinic, an osteoporosis clinic. And so it just kind of harkens back to having those tools in your toolbox and being comfortable with that.
So yeah, you sort of hinted that some of these anabolic agents, like romosozumab or the PTH analogs, aren't a forever drug, right? You have to think about switching them over. So it's not that they can necessarily avoid bisphosphonates, right? Because I hear a lot of patients that are freaked out about bisphosphonates, and they say, "Oh, I don't want to do that." But even if you're thinking about an anabolic agent, usually you want to maintain that bone health with bisphosphonates.
Yeah, you need to follow. So, an anabolic agent, they all need to be followed by an anti resorptive agent. And the other thing to think about is that so you're not getting rid of the likelihood of a bisphosphonate. But I also feel like, it's a dynamic process with patients. And so there are patients who say that, I don't want to take a bisphosphonate for these reasons. And we get them on treatment with something else. There's just ongoing education about it. And I
Mm,
think once they get over that hurdle of taking something, they kind of buy into their own bone health in a different way. And similarly, patients will come, especially to my osteoporosis clinic, and they'll sit down and they'll say, I don't want to take a medicine.
right.
And I look at them and I'm like, I know. That's why you're here. It's my job to educate you about it because if they wanted to take a medicine, their primary care doctor might have started it
Right.
and they might be on a medicine. So similarly with those patients, I, I say it's okay if you don't want to take a medicine, but I'm just going to educate you about your health and your bone health. And then we might have another visit in 6 to 12 months and we'll just check in and see how things are going.
Mm,
And sometimes it's just a process, just like with anything else, where patients need to kind of incorporate it into their thinking and become knowledgeable about it, and then also dedicated to that part of their healthcare. And sometimes, unfortunately, patients will have a fracture while they're waiting to
mm.
decide. And then it becomes a little bit more compelling to them. But, that's why I like to see them frequently, be available to them if they want to have that conversation.
How do you counsel patients about the side effects of some of these medications?
I like to tell them about the things that are most common first. So for oral bisphosphonates, we talk about the gastroesophageal reflux or esophageal discomfort. And for the IV zoledronic acid, we'll talk about and the kind of acute phase reaction that happens with the first infusion. And, that happens in up to 50% of patients. So that's actually a very common side effect. And I also talk to them about ways to mitigate that. So for IV zoledronic acid, there's published literature on if patients take 2 Tylenol before the infusion and then 6 hours later, and even taking it, more scheduled than that, 6 hours after that, it helps to prevent
Hmm.
that reaction. So I like to talk about the more common things first. And then, I usually will talk to them about the less common risks. So And so I'll add with the PTH analogs, the most common things would be some people can get dizziness, some people can get leg cramps, some people get headaches. And so I ask them to take that medicine in the evening, like at bedtime, so they're less likely to have that side effect. And then in terms of the anti-resorptive agents, I talk about the very unlikely but potential adverse effects of osteonecrosis of the jaw and atypical femoral fractures. And I often will talk about osteonecrosis of the jaw first because patients have kind of heard of that jaw thing. And I've also, in part of my history, asked them if they have any upcoming dental work other than, aside from routine dental care. And so I've already kind of crossed that bridge with them in terms of why, as a rheumatologist, I would be caring about their dental health. Not that I don't care about everything, but and so we have a conversation about osteonecrosis of the jaw and that the risk is increased in patients who need invasive dental work done. It's a very, very small risk. It's like 1 in 50,000
Wow.
patients get it. And it seems to be triggered or more likely in people who need invasive dental work. And, the initial studies showed that like 94% of patients that developed osteonecrosis of the jaw in the initial reports were receiving higher dose IV bisphosphonates for malignancy and hypercalcemia associated with malignancy.
Mm.
So it's just a very uncommon occurrence in our own patients. And then patients will often say, well, I don't have anything planned, but like, what if I have to have something in a few years? And then I say, just tell your dentist that you're on this medicine and they'll be extra careful with rinses and your oral hygiene. And, people get these procedures done all the time. In fact, I'll see patients who come in and say, oh yeah, I just had my implant finished. I'm like, hey, you never told me you were having an implant. And then it healed fine. So they can do perfectly fine. And then in terms of the atypical femoral fractures, it seems to be most associated with prolonged use, and it's not a causal relationship. It's actually an association. And so I talk to the patients about how we're not going to treat them for the rest of their lives with these medicines and how we're going to individualize their care, but keeping in mind that the reason to have a drug holiday relates to the risk of prolonged therapy being associated with these atypical femoral fractures. And I explain them that some people can get a fragile bone problem in their femur or thigh bone. And that fragile bone problem on these medicines can result in a fracture that can occur with little to no trauma. I actually had 2 patients who had been on bisphosphonates for a long time who came to see me after their atypical femoral fractures. And literally 2 different people told me they were standing in the kitchen and turned to reach for a dish towel and they heard a crack.
Wow.
And then they fell. And so clearly the fracture happened before the fall. But these also are very rare. And there's a recent publication, I think it's New England Journal of Medicine, that looked at atypical femoral fractures. And I think for every atypical femoral fracture, over 1,200 osteoporotic related fractures are prevented.
Ah, wow.
So again, it's pretty compelling that the benefits far outweigh the risks.
I think often as a patient, I can imagine that's one of the hardest things to see, right? You hear about that 1 in 50,000 of the osteonecrosis of the jaw, or that very rare likelihood of atypical femoral fractures, but it's much more difficult to understand. Well, by not taking these medicines, my risk of an osteoporotic fracture is actually increased. And
Right.
I was learning about the morbidity and mortality of
Mm.
like a hip fracture is incredible,
Yeah.
right?
Yeah.
Is it true that like half of those patients die within the first year
I
after
think it's estimated to be 20 to 25%
a quarter? Wow.
will die in the first year after a hip fracture. And I use that to talk to my patients who are a little bit resistant to taking medications or to emphasize why it's so important. I often ask patients if they know anyone who's had a hip fracture.
Yeah.
And a lot of them will say yes, and that was horrible.
You're like, exactly.
Exactly, because they don't get back to the level of their activity level. They don't get back to the lifestyle that they've been enjoying. So I think that and the mortality. And people don't die of the hip fracture. They die of the disability that it brings with them, the frailty, the pneumonia or the DVT and PE, or, just progressive disability with fractures beget fractures. And patients have, I think they're at a 20-fold increased risk of another fracture within a year.
Wow. And you mentioned briefly about the PTH analogs and romosozumab. How do you decide which of those to use in a patient that you want to use an anabolic agent?
Well, when we were talking about adverse effects, I actually should have mentioned, romosozumab has a black box warning on it related to cardiovascular disease. So in a patient, the black box warning is such that patients should not take romosozumab if they've had an MI or a stroke or a TIA in the past year. But in somebody who's had, advanced cardiovascular disease, but perhaps not an event in the past year, I might also be wary of using it. There are a lot of studies done with romosozumab, or several studies, in thousands of patients, thousands of women. And there was one study that showed an increased risk of cardiovascular or atherosclerotic cardiovascular disease events. And the one study that showed it, I think romosozumab had like a 2.6% incidence, and the placebo group had 1.9%. So, and actually, it may not have been a placebo group. It may have been an alendronate group. So the risk is small, but increased. So, history of cardiovascular disease may persuade me towards a PTH analog. The PTH analogs used to have black box warning on them, and now they don't. That's been lifted. And it used to be that we could only use the PTH analogs for 2 years in a lifetime. And now that doesn't seem to be necessary or a limitation. The PTH analogs are both daily subcutaneous injections, and romosozumab is monthly subcutaneous, and the monthly injections of Romo are done in the doctor's office like denosumab is. So, that might be a difference for patients. Some patients may not be able to come to the office once a month. Some patients don't want to take a shot they have to give themselves once a day. The injectable PTH analogs have like a little gadget that patients can use. It's meant to be easy for patients and older patients to use. So I will often tell them, I watched my 90-year-old grandmother self-inject with teriparatide, and she did a great job, and it was easy.
Amazing.
Yeah.
I think another place where I think osteoporosis is not recognized, or the risk for osteoporotic fractures is not recognized, is in patients that don't have osteoporosis, but whose FRAX score places them at increased risk. And, I often see patients who have had DEXA scans by their primary care doctors, and it says osteopenia, but the FRAX score is elevated, and they don't get treated. So it's still unrecognized. What do you think about those groups of patients? First in terms of why aren't they recognized as having osteoporosis or at increased risk, and how do you treat them any differently?
There have been studies that show that 50% of fractures occur in patients with osteopenia. So it really behooves us to figure out which patients with osteopenia we would predict to be at higher risk of fracture. Again, we're not perfect. So certainly there are patients with lower FRAX scores that may also fracture. But clearly patients who have a higher FRAX score, it should alert us that these patients should be treated. And, I don't know, when patients have high FRAX scores on their DEXA scan and they're seeing their primary care doctor, they may not be treated, but the doctor may have said, I think you need to be on treatment. The patient said, well, I don't really want to be on treatment. And then they move on to the next of 10 other problems, and I think there are lots of reasons that we see patients who are not on treatment who we might like to be on treatment. But I agree with you that I think people with osteopenia and elevated FRAX scores should warrant treatment. I will say that the FRAX scoring system is it's been available to us for, I don't know, over a decade for sure, 15 years or longer. And I think it's undergoing some modification, which I think will be important. It's based on cost benefit ratios, and alendronate was not generic and zoledronic acid was not generic, certainly when the Frax was developed. So now that costs are so low, there may be a reassessment of the cost benefit. And then also looking at different races in terms of risk for fracture and the meaning of bone density, risk is being evaluated. But anyway, that's a sidebar. So I think that when you have a patient who has osteopenia and an elevated Frax score, it's an important conversation to have with the patient to make sure, again, that they're educated that they are at an increased fracture risk and would warrant therapy.
Got it. And do you approach their therapy in any different way as compared to a patient that had, osteoporosis, or
No,
you sort of have the
I don't.
same menu
Yeah,
of options?
no, I think it's the same menu. I probably wouldn't choose an anabolic agent unless, I wouldn't choose an anabolic agent. I mean, if a patient with osteopenia has had fragility fractures, then they would have osteoporosis by definition, and the meaning of the osteopenia is not quite there. But so in somebody with osteopenia and an elevated Frax score, I would not necessarily choose an anabolic agent.
And I was taught in, the brief teaching that I had on osteoporosis during fellowship was that if their forearm T-score is much lower than that of the rest of the bones, that you should consider hyperparathyroidism as a potential cause. Is that still true?
Yeah.
True. Okay.
Yeah, true.
All right. Yeah, I've picked up a couple of patients that have had hyperpara because of that. The T-score in the spine is like minus 1.2, and then on the forearm is like minus 3.2 or something like that.
Yeah, that's awesome. I've never picked up hyperpara by doing that, but I check for it all the time.
Okay.
So I'm glad you found it. That makes me
I'm
feel
not
good.
crazy. That's great.
I know, that's good.
The other thing, for people that are just osteopenic and who don't have an increased risk of fractures, how do you counsel them? What do you ask them to do? And how can, people maximize their bone health sort of throughout their lifetime?
Yeah, I think, again, educating patients on the fact that they have had some bone loss, but it doesn't reach the threshold at which we would necessarily recommend treatment, that this is an opportune time for them to adjust their bone health, and they should be on calcium and vitamin D. I think importantly with the calcium question, I think most of us agree that it's healthiest to get it through diet. So I like for patients to get as much as they can through their diet. And if they need to, they can take a supplement. I think weight-bearing exercise is important, and that, patients come in, they feel so guilty they're not lifting weights. And I remind them that weight-bearing exercise just means you're on your feet. So you're bearing your weight on your feet. And so walking is great exercise. And patients who, it's cold in Boston, they don't want to be outside, they can walk around in their house. They can do laps in the house. They can go to the mall and they can walk around in the mall. I'm not really endorsing necessarily shopping, but they should just keep moving. And then there's the question of, what about kind of some impact type exercise? So things that are starts and stops are good. Things like tennis, that kind of impact on the bones is good for preserving bone density. And, patients will often ask me about, well, what about cycling or swimming? And those are not weight bearing. And they are really great forms of exercise, but shouldn't be the only form because they aren't weight bearing. And so while they help with core strengthening and balance, which are really important in terms of fall prevention, they're not necessarily helping to preserve bone density.
Got it. Tell me a little bit about the fracture liaison service that you created. What was the need for that service? What is it like? And what outcomes have you achieved from that service?
Yeah, a fracture liaison service is really it's a way to provide a seamless transition between the inpatient fracture care and the outpatient management of the underlying problem of osteoporosis. And getting back to your point about why is it that osteoporosis is underrecognized? This is a prime place where it has historically been underrecognized and definitely undertreated. When patients suffer a fragility fracture and they come in, let's say a hip fracture, and they come in, they get it operated on, and then they're better and they go home and they go to rehab, it wasn't necessarily considered that this has an underlying medical problem. And so it is well known that it's an underlying medical problem, but despite that, the treatment for it has been there's been undertreatment for fragility fractures. And it's not really clear why, because we know that patients have osteoporosis when they have fragility fractures. And again, I think it's one of those situations where it's kind of lost in the shuffle, where patients have a lot of comorbidities. They might go from the hospital to rehab, and then they later go home and they might see their primary care doctor, 6 months later. And, there's 11 to 8 other things going on too. So the fracture liaison service is a way to ensure that treatment is started. It's to ensure education of the patient, to ensure that the patient realizes that they have an underlying medical condition and that needs to be addressed. Because by just discharging a patient from the hospital and saying, you have an appointment in endocrine or in rheumatology, many patients would just cancel those because they are like, I don't have diabetes or thyroid. I don't need to get an endocrine. I just had a hip fracture. So the fracture liaison service helps to really anchor that treatment. And what we've done at our institution is, first of all, we had a needs assessment and we saw that our patients weren't getting treated and follow up from the inpatient service. And so we established a pathway where the patients were identified who we initially started with hip fractures because all those patients get admitted, and we had them identified in the emergency department, and the fracture liaison service was consulted by the orthopedic resident. And so we had the ability to see those patients, and then we could educate them and initiate treatment. And what we saw was at our hospital, we went from less than 10% of patients being on treatment at 6 months to of patients who were able to get treated, like other health conditions, and were able to be followed up by us to know, because certainly not everybody is followed up at our hospital. But of patients that we could capture data, we went from less than 10% to 70%.
Wow.
Treatment rate. Yeah. And something that's really unique to, I think, what we've had several publications recently related to the fact that we also administer IV zoledronic acid in the hospital post-fracture.
Wow.
And that ensures treatment, and it gives them a year of treatment. So it's not like starting a medicine that the patient has to take, an oral bisphosphonate, and then it kind of falls off the med list or they go to rehab. Anyway, so I think that that's really been a very effective way to initiate treatment and ensure treatment. And then once they've gotten the IV treatment, they're really good for a year. So you don't have to, it's not cumbersome in terms of all the appointments that are happening right after the hospitalization. They don't need treatment again for another year.
Are there concerns about the use of bisphosphonates in the acute fracture setting?
There's some theoretical concerns that haven't really been borne out. There was one study that looked at early treatment with bisphosphonates, and there were increased poor outcomes, I think related to heart disease. But in any event, the patients that received the treatment had a lot of comorbidities. And we know that there are poor outcomes if people have hip fractures and don't get treated, and 20 to 25% die in a year, or they're more prone to other fractures. And so we're looking at mortality data, and we have unpublished data that looks very promising.
Amazing.
Yeah. And so it's been really rewarding to see that we can make a difference.
And is that something that happens automatically, or are the orthopedic residents told that they need to page you guys?
Oh, no. Yeah. No, there's a fracture liaison service. And so now we are consulted on any patient admitted for a fragility fracture. And we're also consulted on, say, a patient, you brought this up earlier, a patient comes in to the general medicine service, and on their chest x-ray, not only do they have pneumonia, but they have, two vertebral fractures, and they don't have a history of trauma. And so then the fracture liaison service is consulted to address the bone health for those patients. Or a patient is admitted who had a hip fracture a year ago and isn't on treatment. The fracture liaison service is consulted to address the bone health for that patient as well.
How are those patients identified? Is that something that happens automatically, or the internal medicine team is told to page you guys when they see those x-rays?
Yeah, no, we've done some education so that the other services know about us. And there's a consult in Epic for the fracture liaison service.
Amazing. And who staffs that service? Is it you or endocrinologists or rheumatologists?
We started out as having an advanced practice provider. We had a wonderful PA
Hmm,
who did all the consults. And we've transitioned, actually, we have a physician, an endocrinologist who does all the consults. And so
amazing.
he sees all the patients and establishes their follow-up, whether it's with us or if the patient has an outside primary care provider or outside endocrinologist or rheumatologist.
Amazing. That's great work, Marcy. And it's incredible to see those less than, 10% of patients receiving treatment to 70%. That's a
Yes.
huge, huge improvement.
Thank you. It's been really, really rewarding.
Where do you see the future of osteoporosis treatment going? What's in store? Are there new medications or new ways of identifying these patients? Where do you see the field headed over the next few years?
I think that we're always striving to identify patients earlier and ensure primary prevention for fractures as opposed to having to be in the position of secondary prevention when a patient has already fractured. And I think that we look forward to new medications, new mechanisms of action. We look forward to better understanding the drug holiday, how long, when should the holiday occur, how long should it last, if there are any nuances to the treatment that follows an initial treatment. And I think learning more about the anabolic window and improving the number of patients or increasing the number of patients who might be candidates for building bone before preserving bone from being lost. And, being really innovative in how we identify patients. I will add, we started to talk a little bit about the patients with vertebral fractures. And, the impressive thing about vertebral fractures is that that's the site where most fractures occur. So vertebral fractures are the highest number of fractures, and 2/3 of them are asymptomatic. So we
Hmm.
certainly know about when patients have symptomatic, what's called clinical vertebral fractures and come in with pain. But knowing that 2/3 of them are actually asymptomatic and are harbingers for, okay, this patient has osteoporosis and needs to be on treatment, but they're silent. And so finding those patients as well and being able to make a difference.
Great. And for rheumatologists listening who are convinced by your arguments and feel like, they should do a better job about, evaluating and treating osteoporosis in their patients, what resources do you recommend that they read or access to try to help improve their knowledge and comfort in some of these medications?
Well, first of all, I would say embrace the challenge. Help your patients in their totality. There are great resources. The Bone Health and Osteoporosis Foundation has great resources for physicians and for patients. The International Osteoporosis Foundation has resources. The American College of Rheumatology has resources. We published a book a few years ago, if I can mention that. It's meant for patients, and it's called Facing Osteoporosis, and it's really organized chapters by questions that patients ask.
Hmm.
And so I think that that's been a really useful resource for patients to obtain. And there are, reviews and summaries that are published. There's certainly guidelines that come out from the Endocrine Society as well as the American College of Rheumatology, and lots of reviews to be able to enhance the way we think about things.
Amazing. So if you could share those with us, we can put them on our website, acronair.org, and then listeners can just access, all of the resources that you mentioned. Marcy, thank you so much for your time. This has been certainly eye-opening, and I'm so interested in getting back to my patients and asking more about their dental health and screening them
There,
with DEXA scans and being a little bit more assertive about addressing their bone health. So thank you so much for your time and for everything that you've done for patients.
John, thank you so much for inviting me to this podcast, and thanks to the ACR for promoting this.
Well, there you have it. Everything you ever wanted to know about osteoporosis, but were afraid to ask. Dr. Bolster's insights underscore the importance of early intervention, patient education, and the judicious use of medications. It's a call to action for both patients and healthcare providers to prioritize bone health as a crucial aspect of the care of people with rheumatic disease. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars or however many stars you think we deserve.
You can find our show notes for this episode at acronair.org, Apple Podcasts, Spotify, and on your favorite podcast app.
Until next time, let's keep assessing bone health in our patients with rheumatic disease. And of course,
Stay healthy.